So, I'm getting the signal that everyone's connected. Hi, ladies and gentlemen. Great afternoon. It's a pleasure to have you here. We're grateful that you decided to join us for this little live stream. The main topic will be the treatment, infertility treatment with donated eggs or with donor eggs. We received some very interesting questions, which I'm looking forward to answer a little later, and thanks to that, I can keep the introduction rather short, and we'll be focusing more on your specific questions. You can also ask during this webcast or this live stream. Just simply type your question in the comment section of the video, and it will be passed on to me, and we'll get to them towards the end of the presentation or of our little get together. I know it's going to be more fun in person, but this is a good start, and the COVID-19 precautions are slowly and carefully easing up. We have patients from abroad who are traveling in already. There were several this week, and everything seems to work out quite nicely with the right paperwork. So I'm sure, if need be, we'll see ourselves soon, and I'm looking forward to that. Okay. It is important, of course, to individualize and to try to take into account all the factors that can play a role in the couple's treatment when trying to get pregnant, when originally unsuccessful, and when maybe going through IVF cycles with the stimulation of ovaries without success. We will try to generalize a little bit and talk about the right time, the conditions, the procedure, but once again it's really crucial to see what the specific situation is, what the ages of both partners, what some of the lab results are, or exam results are, like a spermiogram on the side of the gentleman or the ultrasound on the side of the woman. But when do we start to talk about a cycle with egg donation? It's usually when there's a more severe or complicated diagnosis, or when there's multiple cycles without success. Generally, we need to keep in mind that the IVF approach, it doesn't always work right away. The success rates and right age group, let's say until 35, there are about 50, 55, 60% after transfer of one embryo. So they're gradually increasing. They're much better than they used to be like 10 years ago, but still it's far from 100%. We need to be patient. We need to take into account all the factors that can play a role, and only when it seems that we have actually taken care of everything, there's no more explanations, no other way to go, no other route to take, and there's very often multiple IVF attempts without any success, then it's time to talk about alternatives. When we think about the possible causes of a repeated failure, we need to keep in mind that at least it's published that way, that approximately 80% of the responsibility carries the embryo itself. And of course, the two major players there, it's the sperm cell and the oocyte. So the quality of the embryo often decides. As far as the quality of the spermatozoa goes, of the sperm cell, we do have options as regarding the examinations. The spermiogram does give us a general idea what the concentration is of the cells, what the motility rate or the percentage of sperm cells with the right morphology is. There are some more sophisticated and modern examinations, like the testing of the DNA fragmentation rate of the sperm cells, and there are now some methods actually for sperm selection for the fertilization, such as PIXI, MAX, or the fertile chip, which might be interesting and which might actually help us in this regard a lot. However, with the eggs, and we want to talk about those mostly today, it's much more complicated. During the normal, the natural cycle, the menstrual or ovulation cycle, if you will, there's usually one dominant follicle, and in this follicle, one ripe egg. The normal number, or the usual number of follicles per ovary in each cycle is somewhere between 5 and 11. That gives us a total of 10 to 22 anther follicles. So this is the number of follicles that we usually see. It's far from the millions or dozens of millions of sperm cells that we see in the gentleman. In each exam, here we're working with single eggs usually. And we don't really have an easy way to approach to get the egg. And we have very, very, very few ways how to examine it. So it's much more complicated. And here we are usually stuck with the general exams, such as the estimation of the ovarian reserve, using AFC anther follicle count, so the number of follicles in the ovaries on each side, and the AMH, anti-Müllerian hormone. Usually these go hand in hand. The higher, the better, just very generally, very simply. And these can help us eventually, along with the other factors, the age and previous cycles, and other diagnoses such as endometriosis or possible genetic problems, help us decide whether it's time yet to think about egg donation, whether to discuss it or not. Interestingly enough, it's often much easier in the group of patients with a more difficult situation, where there's premature ovarian insufficiency, meaning that the ovaries are not able to produce the follicles and get the eggs to ripen anymore before the age of 40, when there's a lack of a menstrual cycle, and the hormone levels usually show us that it pretty much represents an early menopause, so to speak. Or after 40, the regular menopause. Once again, there's just no question that the ovaries probably won't be able to bring any more eggs, no matter how hard we try, no matter how high the dose of FSH, follicle stimulating hormone, we use for the stimulation of those. And there are, of course, the surgeries and the genetic diagnoses. Anyway, whenever there's a situation when there's just no way to obtain the eggs, it's rather simple. If there's a really a strong wish to get pregnant and to carry the child, then the egg donation does represent the strongest alternative. Of course, there are other very good alternatives, such as adoption, etc. But with the egg donation, you will carry the child. The woman carries the child from day 5, following the transfer in her uterus, and the connection with the baby is very strong, and her influence on that baby and its development and upbringing is very, very strong. There is a red line that goes through all of these, and that's always the age. The age of the patient usually plays a very strong role, and we'll get to that in just a moment. Unfortunately, there's really no arguing with nature in this regard. Unlike the gentleman who produces the sperm cells always fresh, so there is a gradual decrease in the quality of the sperm cells. In the woman, it's different. She gets born with all the primary oocytes, with all the eggs, and these eggs eventually then grow older with her. So the quality of the eggs is still best, this is a little simplified, between 20 and 30 years of age. It's still very good until 35 years of age, but then it drops rather fast. And after 40, it's really problematic to achieve a pregnancy from own eggs, be it naturally or via IVF. the IVF treatment success rates, for instance, may be over 50% in women up to 35 years of age, but between 35 and 40 it drops gradually to about 14%, and between 40 and 45 years of age it's published that the success rates of IVF are somewhere between 1 and 3 or 1 through 5% of success, which is very, very low. And in contrast with that, a cycle with egg donation, where the age of the egg, the oocyte, decides and is crucial, the success rates remain over 60% following a transfer of a single embryo. So is it possible to get pregnant with own eggs after 40? In most cases, yes. But the chance that you're going to be the lucky one, this 1 out of the 100, they're rather low. And the success rates with egg donation are much, much higher. So when do we consider egg donation? Well, it's pretty much summary of what we talked about. Whenever there are no more eggs, not produced, but actually getting ripe in the own ovaries, or when the ovaries are missing, be it genetically or following a surgery, when there's a premature ovarian insufficiency, usually without any explanation. The only guide there, if you're trying to estimate your ovarian reserve, and I think, although this presentation that I heard years ago is rather old, but I think it still holds, and there's just two things you can do. AMH, so have the anti-Müllerian hormone tested and ask your mother. So see if there was any problems in the family with early menopause, if there might be a hereditary influence, and if your mom happens to say, oh yeah, I had you with 28, but then with 33, 34, my menstruation actually just stopped. This might be a bad sign, and it might mean that your ovarian reserve is going to get lower just as well. So an alternative there would be possibly just a social freezing, stimulation and freezing of the eggs, but that's a different topic for for another time. Another point here, the poor oocyte quality. This goes hand in hand with what I said earlier about the previous cycles. When there's no previous treatment, it's always, or usually, a good idea to try. And most specialists from this field will tell you, if you ask them, well, with what AMH level should you not stimulate anymore? When does it not make sense anymore? They will usually answer, no AMH value or level should serve as a disqualifying factor. So you can always try, but the lower the AMH, the lower will be the number of eggs that you obtain, and eventually the lower might be the chances to win. Still, 1, 2, 3 cycles makes sense, but if it's 3 and more without any success, no eggs obtained, no successful fertilization of the embryos, or very poor in vitro development of the embryos in the lab during that 5-day cultivation, poor or repeated implantation failure is actually the right term, or multiple early abortions. These are all situations where you might want to rethink the strategy and discuss donated eggs. And once again, the age plays a very important role, and after 40, the donated eggs usually come into discussion sooner or later. What are the basic rules? The procedure, the process with egg donation is fully legal in the Czech Republic, has been for years and years. It's slightly different from other countries in Europe or the world in that regard, that it's not an open donation. It's at least this year still, an anonymous donation by law, so we are not allowed to share the identity of the donor, but on the other hand, the donor never learns who received the eggs. the European community might actually push and try to change that, or change that, since the Czech Republic is part of the European community, and they might actually change that into an open donation to unify it with the other countries. But at least this year it's still an anonymous donation, so you should know that and take that into account with all the advantages and disadvantages that it might have. And I'd be more than happy to discuss these in more detail with you eventually. The donors, it has to be an altruistic process, so they're not paid for the eggs, but they do receive a certain reward, and they have to be by law between the age of 18 and 35. However, we take women preferably between 20 and 29 or 20 and 30, so that the quality of the eggs is best and the success rates high. Of course, the candidates, this is a study performed by ESHRE, where they asked the donor candidates, just out of interest, why they decided to donate. For pure altruism, just to wish to help somebody, was 50%, half of them. Then 34% actually admitted both the altruistic and financial reasons, and there were a minor part who had other reasons, or just purely financial reasons. The testing is very strict, and it's pretty similar, or it's pretty much the same all over Europe or in the world. These are international guidelines that we need to follow, and that in some regard are actually even the testing procedures more strict in the Czech Republic, because we have a very agile Society for Genetics and Genomics that recommended, starting in 2011 from January, it's mandatory to actually perform some more tests that are usually performed elsewhere in Europe. The candidate for donation, the young donor, has to go through a series of examinations, a health interview, psychological review, blood tests for hormonal levels, for infectious diseases. All of that has to be perfectly clean, negative. Then a genetic consult with a clinical geneticist included. Are blood tests for karyotype, cystic fibrosis, and since last year also muscular atrophy and hereditary deafness. Only when the geneticist writes down that all the results are perfect, that the person is not a carrier of any mutations, there are no problems in her family, and that she is actually capable or fit for donation, only then she's included in the database and then selected from the database for the couple, for the patient. The match is being performed based on looks, phenotype, based on blood type, and of course menstrual cycle eventually, because we need to synchronize these both women. We can do that easily, fairly easily, with the help of a pill, but the closer the menstrual cycles or their timing is, the easier it might be. I would say that we're not able or allowed to share the identity or the full identity of the donor. However, during the donor selection, there is a number of factors that we can share with the patient or with the couple, such as the age of the donor, her blood type, her eye color, hair color, height, weight, and her profession or study orientation, because over 80% of them are students of the university. And of course, if you want to discuss with your coordinator some other details such as personal interests, hobbies, then we can always ask, and we can always try and dig a little deeper. Then the procedure in this case is much more strenuous for the donor, actually, at least physically. Psychologically, it's a whole different question. But while there's only 2 visits actually marked here for the donor, it's really about 5 of them, because during the ovarian stimulation there need to be multiple ultrasound checks, and then ultimately the egg retrieval is performed at the right time in complete anesthesia. In the meantime, in the patient itself, we prepare the endometrium, the uterus, and the uterine lining for reception of the embryo. This is usually performed using hormonal substitution therapy or hormonal replacement therapy pills. Very simple. It's just estrogen in the first half of the cycle to build up the endometrium, and then progesterone in the second half needs to be added up so that the endometrium steps into the secretory phase and the blood flow is increased and it gets perfectly ready for the embryo. This needs to be checked via ultrasound, but that ultrasound can be performed actually at home. So in your country, you just share the result with the coordinator, and it's checked with the physician whether the doses of the hormones of the estrogens need to be adjusted, or whether everything is up to par, whether we are up to speed as far as the endometrial height and structure goes. So that's one visit here, the ultrasound. The second point here, actually, the crucial one, when the egg is fertilized with the sperm cells, that represents a visit for the gentleman, for the partner of the patient, because he needs to provide the sperm cells for the fertilization on that day. And then 5 days later, following the 5-day cultivation until the stage of the blastocyst, the transfer is performed. And this blue pointer, actually this file, it represents the only time when you need to, absolutely have to come to the clinic, because that's the day when the embryo is inserted in the uterine cavity. Approximately 2 weeks later, the pregnancy test is performed. Once again, that can be performed at home. And another 2 weeks later, which represents week 7 of the pregnancy approximately, an ultrasound is performed to confirm the pregnancy and see the heartbeat of the baby. So the preparation for the patient herself is actually relatively simple: estrogen, progesterone, and vitamins, folates. And these are actually the same hormones that you have in every cycle, so it's nothing really too strenuous or too difficult. As far as the endometrium go, we always discuss it with the couple individually. We check individually, we set the dosage of the medications individually. It should be somewhere between 7 and 12 millimeters, the height of the endometrium, and let's say 8 through 10 might be optimal, but the structure of the endometrium is actually sometimes more important than the height itself. Okay, I have a couple more slides here that I'm just going to rush through, if I may. Why is the embryo developed until day 5? Because that way we learn actually a lot about it. Many of the embryos actually stop during that 5-day in vitro cultivation. But on the other hand, the ones that really do develop and that do reach the stage of the blastocyst on day 5, they see, and these are the best embryos for the transfer or a possible cryopreservation. The transfer can be performed on day 3 or day 5. We do prefer day 5 because until day 3, the embryo pretty much develops from whatever the egg brings into the relationship, and from day 4, the influence of the genome from both sides is getting stronger. So the role of the sperm cell is much stronger. And if the embryos stop during that 5-day development, it's usually on day 4 or 5. So if we want to use this as a selection process, then we feel that the cultivation until day 5 is actually preferable. Why do we always talk in plural? Why do we want to have more eggs and more embryos? Well, the reasons are here, but you probably have heard most of this before. Not all the follicles during the stimulation hold an egg or provide an egg. Not all of the provided eggs obtained via the puncture, via the oocyte pickup, are ripe. Not all of the ripe eggs are healthy. Not all of the healthy eggs will necessarily be successfully fertilized. The sperm cell is actually inserted, the selected sperm cell is inserted via ICSI, the intracytoplasmic sperm injection, but after that, the cells overnight in the incubator, they just need to cooperate. They need to really have the will to work together, and if they don't, there's no way to force them. So not every egg is successfully fertilized, and as I said earlier, not every embryo successfully develops until day 5. So we want to start with a reserve so that we would have a relatively strong number of embryos on day 5. Also, not every embryo following the insertion, no matter how careful and perfect, gentle the transfer is, results actually in a pregnancy. These are some numbers that might be interesting. The average age of an egg donor, 24 years of age. These are numbers from the last 3 years. The average number of obtained eggs, 11.5 per cycle. The maturation ratio or rate is 87%, fertilization rate 75% from those ripe, those mature eggs. The average of embryos on day 1 is 7.5, and the average number of embryos per couple on day 5, so following that 5-day cultivation, is 3.6. The success factors, we have pretty much covered those. The quality of the sperm cell, the age of the egg donor, and then eventually the quality of the egg, but that goes hand in hand with the age. The retrieval process, the embryo quality, the quality of the transfer, the quality of the endometrium, the height of the endometrium, and of course we wanted to cover all bases, so we care about an eventual hematological or immunological factor as well. Just a couple of more practical pointers. After the transfer, there can be some spotting or bleeding experienced. This doesn't automatically signal the risk of miscarriage. What is the procedure that we use here actually after the transfer? No bed rest is necessary, really. There are even studies that show that the length of bed rest following the transfer doesn't really influence the success rate of the cycle. And it's logical because whenever the woman gets pregnant naturally, in the initial weeks of the pregnancy, she has no idea, she doesn't even know it yet. And she performs all the activities as she's used to without actually any major effect on the pregnancy, any detrimental effect on the pregnancy. So the bed rest is not necessary. But still, following the transfer, we usually let the patient rest for about 10-15 minutes in the bed, and then for the rest of the day it's pretty much normal regime. You're welcome to travel home, although personally I think that it's a good idea to travel the next day because there's always a little stress connected with the traveling, but it is possible even on the day of the transfer, and we recommend a gentler, more relaxed regime for the next 7 days or so, refraining from heavy physical exercise, heavy lifting, sports, contact sports, and it's a good idea perhaps to wait with the sexual intercourse for a couple of days after the transfer. What can you do actually during that phase? Honestly, there's not a lot we can do at that point. It depends on the quality of the embryo, on its will to continue, and on its ability to nest and develop further. So the patient takes the hormonal medications for supporting the endometrium. A balanced diet is a good idea. Moderate exercise, this can be individual, a little different for each and every person. Avoid high levels of stress if possible at all. I'm well aware that the treatment itself is actually quite stressful already. Avoid harmful substances like drugs and alcohol. Alcohol with moderation might not be a big problem, but still, moderation is the word. Okay, thank you very much for your attention during this part. And if I may, I'm going to take a look at some of the questions that you have sent earlier. Once again, if you have more questions at this point, don't hesitate to type them up in the comment section of the presentation, and we'll get to those in just a little bit. So, first question from Shelley, I guess. What age is considered too old for egg donation or for donor egg treatment? Thank you very much for the great question. Actually, all of them very interesting, and it's fun to answer. The age of the patient, the age of the recipient, doesn't really play a major role here as far as the ability of the uterus goes to take care of the baby. So it's more an ethical question and a social one and a psychological one. To what point are you willing to go to try? However, since I think 2012, there's a new legislature actually effective in the Czech Republic. And there's a limit now that's actually given by the law, and that's 49 years of age. So any treatment that we perform, we are able and allowed to do it until the 49th birthday of the patient, of the future mother. After that point, we're not allowed to perform any transfer. So there's no difference as far as the success rates go. If the patient is 38, 42, or 48, if we talk about egg donation, of course, but there is a limit, and that's the 49th birthday. Of course, I have to admit that this is not a reason or cause to postpone the pregnancy, because especially in a woman that gets pregnant for the first time after 40, the effects of the pregnancy on the organism generally and the possible complications are actually more frequent, I have to admit that. So there's no effect on the success rates really, but there might be high risk for the patient herself. It's different when she actually was pregnant or gave birth before, then it's that influence, the negative influence, or these risks are not that high. Next question from Tracy. Can you do treatment for a couple that needs sperm donor and possibly egg donor if the female eggs are of poor quality and the woman is 39? So that's a clear yes on all counts. We do have both female egg donors, we have also male donors, sperm cell donors, and a combination of the two is possible. The rules actually for both the egg donation and the sperm donation are quite similar, they're very close. Again, it's an anonymous donation, and the success rates, of course, are very high, since here where both donors are young, both donors are thoroughly tested, including genetics, then the cooperation of those gametes, of those sperm cells and oocytes is usually very good, and the numbers of embryos are good, and the success rates very high. Next question from Ilona. Can you be pregnant with egg donation if you have endometriosis, low level of the anti-Müllerian hormone, the AMH, and an endometrial polyp? Very interesting, thank you for that question. And the answer would be yes, yes, and yes, but with a note for me. So, endometriosis can be the cause of premature ovarian insufficiency or failure and of low ovarian reserve. It can be the cause why the ovaries are not capable, be it because they're damaged by the process itself or by the surgeries where the endometriomas, the cysts caused by endometriosis, have to be removed. So the ovarian reserve can be quite low, and in some cases we are just not able to obtain any right eggs via the ovarian stimulation anymore. So that is actually, such a patient is a perfect candidate for egg donation, and the success rates there are very high. The same goes for the low AMH. That's usually just a sign, for instance, with the endometriosis, when the ovarian reserve gets lower, that means that both the parameters of the ovarian reserve, and that's the anther follicle count, the number of follicles, and the AMH, the anti-Müllerian hormone, they will also be very low. And it's the same answer. When the AMH is critically low, then we also always need to have to take into account all the other factors. Is there still a regular cycle? What is the age of the patient? Are there any follicles? Is there reaction of the ovaries to previous stimulations, etc., etc. But this is actually a situation where the egg donation helps the most. As far as the endometrial polyp goes, yes, you can get pregnant and we can perform the treatment, even finished by the transfer of the embryo, but the polyp might disturb actually the milieu in the uterine cavity. And if it's a polyp that can clearly be seen with ultrasound, it's a good idea to get rid of it before we start the cycle with the transfer and before we put the embryo in the uterine cavity, because we want to pamper it, we want to spoil it, we want to make the conditions in the uterine cavity as perfect as possible, the right height, the structure of the endometrium. We want all of that to be just fine, and the polyp might disturb actually the embryo. Also, it's not that complicated to get rid of it. It's usually a question of a hysteroscopy with a polypectomy, and the recovery is very fast, and you might have to postpone the treatment cycle and the pregnancy by maybe a month, but it's not a huge problem. We have some other questions here. When we get to those, also I'm going to check if there are any new questions during the presentation. We'll get to those in just a little bit. So, what are my chances with 43 years of age with my own eggs versus donated eggs? We have pretty much answered that question already. With own eggs, somewhere around 1%, 1 through 3 perhaps. With egg donation, it's over 60% with the transfer of the first embryo. Of course, the cumulative success rate, if you have, let's say, 4 embryos on day 5 of the development, 4 well-developed embryos, and therefore 4 chances, 4 transfers, then the cumulative success rate sometimes reaches over 90%. But it depends how the gametes, the cells will cooperate and how the embryos will develop. Another question, okay, how high is the possibility to get pregnant with egg donation when the sperm cells actually are of lower concentration and their quality isn't perfect? However, there always have been enough for a successful ICSI fertilization. Same answer, this doesn't necessarily have a dramatic, the quality of the spermiogram doesn't, to a certain extent, have a dramatic influence on the embryo development, the success rates. However, when the numbers are critically low, the concentration extremely low, motility, morphology that can have an influence on the embryos, and in such a case, we have to look into it. We have to once again consider the development of embryos in the previous cycles, if there are cycles like that, the spermiogram, other examinations, and eventually think about the special methods of sperm selection for the fertilization, so just so the quality of the sperm cell is possibly the best. But one thing that's important here to say, with egg donation, there's another actually positive factor that might play a role. The reparative ability of the egg, of the oocyte, is very high at that age. The younger the egg, the higher the chances are that it's going to deal even with some problems in the sperm cells. So once again, the chances here should be very high. There is an interesting question here about coronavirus. What's the influence on the baby in utero, okay, during the pregnancy, and to that, and there's a couple of similar questions actually in that regard, to which I have to respond. We just don't know yet. A direct transfer of the virus via the pregnancy in general has actually not been confirmed, and it's very early actually to estimate that. The data is being collected, the studies will come eventually, but so far it hasn't been proven that actually the baby could get infected in utero, that there would be transfer via the amniotic fluid, and then there would be any effect on maybe a higher abortion rates or early abortion or miscarriage rates, things like that. We're just collecting that data. Will generally all over the world. The studies will be available, some of them shortly, the solid ones eventually later, but it's going to take some time. It's very hard to actually make a clear-cut recommendation in that regard. Even the big societies such as ESHRE, the European Society for Human Reproduction, they are still, very careful in their recommendations. However, there are some discrepancies to be seen. It might be a little different for actually what the recommendation is for like a natural pregnancy, actually no real worries there, versus via the IVF, where 2 weeks ago approximately it was still in those recommendations. It was suggested to wait with starting the IVF cycles, the IVF treatment. However, new recommendations are issued pretty much on a weekly basis, and the situation develops very fast. So we'll have to take into account the current situation, the rules or the recommendations at the specific state at the moment, and we'll take all of these into account. The next question takes a little further. When will it be possible to come for a personal consult, to come to your clinic? How fast after the consult can we start? And will there be a PCR test necessary when we plan to come? So as far as the consults go, it is possible already. I have 2 tomorrow. I have many more planned for next week. And the patients actually from the neighboring countries, Austria, even from Romania, I think there's a consult plan for Tuesday next week, are able to come. There's a little more paperwork than usually in play that we need to take care of. You will receive some forms that you need to sign, and you will receive actually from us some documents that prove that you are actually treated or plan to be treated with us, and that you're coming for these reasons. As far as the PCR tests go, if you're not planning to stay longer than 24 hours in the Czech Republic, then you don't have to have a test. And actually all the visits here, even as a part of the egg donation treatment, usually don't take longer than a couple of hours. So you don't necessarily need a test. You will, however, need to sign a document saying that you're not infectious, you don't have signs of the infection, you haven't been in contact with the person infected, you're not in quarantine at the time. But we'll specify that, and this also develops and changes rather rapidly. Now, the last question there, how soon after the consult can we start? Usually, the answer is, well, whenever the next menstruation comes, because the whole procedure needs to be set in the natural settings and the natural menstrual cycle. So we start with the preparation of the endometrium from day 2 of the cycle. So we always ask, when was the last period, the last bleeding, and when do you expect the next one? And if all goes well, and if that is your wish, we can start very soon, meaning from the next period. The whole procedure itself then takes about 3-4 weeks. So with that waiting period, it's usually somewhere around 6 weeks total. But when can we start? The answer is usually within a month. Okay, thank you for all these questions. I'm just going to check one more time if there's anything new, and I don't see one at the moment, so I will. Thank you very much for your attention, for joining us, and there is a question? Oh, okay, but, oh, there's a couple. Thank you. All right, let's take a look at these. What is the overall percentage of success rate for egg donation? I'm 32, had early menopause diagnosis, had a miscarriage in January in a surprise natural attempt. Okay, wow, I'm sorry you were so close. Okay, the percentages are just like I said. Following the transfer of one embryo in the first cycle, the first transfer, the success rates are somewhere between 55 and 60%. But if we have more embryos from that one stimulation cycle, once again the average is 3.6 per couple, then even if the first embryo doesn't succeed, then we can try again in about 5-6 weeks time, and the cumulative success rates are even higher than that. They're somewhere between 75 and 90%. The early menopause shouldn't play a role there. One pointer though, I don't think we have mentioned that yet today. With the early menopause, quite often the menstrual cycle stops and there's just no bleeding for months or even years. That can actually be bad for the uterus. When it doesn't get the support and the exercise, okay, caused by the hormones, estrogens, progesterone, then it tends to shrink and become hypertrophic. So if there is a wish to get pregnant eventually, if you're thinking about that, it might be a good idea to discuss it with your gynecologist and take some form of hormonal replacement therapy, some form of estrogen and progesterone to keep everything alive. But even if there was no menstruation for 6, 12, 24 months, we can still succeed. However, in such a case, it's usually a good idea to start with the substitution, with the hormonal replacement for about 2-3 months, check on the uterus, see if it reacts, if the size is okay, if everything's ready, and then perhaps plan the treatment cycle. But the success rates, as I said, are approximately 60% with one embryo. Next question. My first transfer cycle was interrupted due to COVID-19. Any information on when travel will be allowed for IVF? We have talked about that already. It's individual and it might differ from country to country. So I cannot guarantee that your side, that your customs office will let you come in. But we have had 3 transfers with international patients today, and all of them have gotten through without any problem. There are some special documents that are issued, for instance, by the Austrian government if you travel through Austria. There are some documents that we issue ourselves, actually stating that you're treated with us. But with these documents, neither of those patients had any problems. So it should be pretty much possible already, but it might differ from country to country. Okay, unfortunately my endometrium wasn't ready when the transfer was programmed, and I had to freeze the blastocyst. Now, what are my real possibilities? Oh, this is a very, very good and a very tough question, and this would be for a presentation in itself, actually. But there are things to try and ways to go. The endometrium might not always react to the usual dose of estrogen hormones as we wish, and it might not always have the right height. Freezing the embryo or embryos is not a tragedy, because nowadays the cryopreservation procedures are very gentle, and the success rates with the cryopreserved embryos, which used to be some 7 years ago much lower than in the fresh cycles, are almost the same now. So that's no tragedy. The question, however, is how do we prepare your endometrium to be ready? To answer that, we need to look in your history, see what might have caused that poor build of the endometrium, number one, so try to see what the reason is. Number two, maybe run a test cycle at first, because now the embryo is already resting in the cryobank, and it can wait a little, and we can play with the endometrium until we're happy with the height, with the structure, until we're perfectly ready for the transfer. Well, and number three, the good news is that in such a regard, there are alternative ways how to prepare the endometrium, which might not be available for the fresh transfer, because during the fresh cycle with the egg donation, the timing is actually dictated by the ovaries of the donor and their reaction to stimulation. But in the transfer cycle with the frozen embryos, we're free. So we can work on the endometrium, and only when we're happy, then the embryo is warmed up, thawed, and transferred. So there are possibilities. The first one would be the so-called frozen embryo transfer, but there will be probably some detailed and careful preparation necessary. Okay, thank you very much for joining us. Thank you for your attention. It's still kind of funny to talk into the lens of the camera, but I'm hoping that if need be, that we'll meet and talk in person soon, and I hope we'll be able to help. Okay, stay healthy and good luck. Thank you very much. Bye.